This is Nazir Habib, and today I would like to review an important topic, necrotizing soft tissue infections, which is often a challenging problem for the physicians and the team involved in managing these patients. My objectives today are to recognize the mortality associated with necrotizing skin infections, explain the pathophysiology of necrotizing skin infections, review the clinical presentations and types of necrotizing fasciitis, initiate appropriate antibiotic therapy immediately, and initiate emergent surgical interventions to reduce mortality and morbidity. So let us review this case presentation. This is a 50-year-old Asian male with no significant past medical history. Is seen at 6 a.m. in the emergency room with a painful right heel that developed the previous night. He has had fever and confusion for 3 to 4 hours prior to arrival. On examination, his temperature is markedly elevated, 103 degrees Fahrenheit. He has a tense heel associated with erythema and tenderness, and he is mildly confused, and his blood pressure is decreased at 90/50 with a heart rate of 120. Initially, the impression was the patient had gout or possible deep vein thrombosis, although this ultrasound is found to be negative. The lab data shows that his white cell count is 9.9 within the normal range. However, he has significant bandemia of 36%. His hemoglobin is normal, and also alarming is that his lactic acid is markedly elevated at 3.8 millimoles. His creatinine is 1.8, which is abnormal, and his serum sodium is 132. Consultation with the hospitalist at 9 a.m. results in admission to the intensive care unit, and an orthopedic consultation is requested, and patient is taken to the operating room at 11 a.m. In the operating room, the patient was found to have significant discoloration in the muscle bellies, as noted here, as well as the presence of dishwater drainage at the time of surgery, which was sent for gram staining and culture and revealed gram-positive diplococci and group A strep infection, consistent with the diagnosis of necrotizing skin infection. The patient had repeated exploration and made a steady recovery and was discharged. So let us review necrotizing skin infections. What are these? The diagnosis of necrotizing skin infections is a surgical and microbiological diagnosis. There is a notable absence of pus, and what we consider or frequently call dishwater exudate is what is noticed at the time of exploration. Also at the time of exploration, there is noted to be widespread tissue necrosis, destruction of the dermis to deep muscles and tendons. This is what results in the severe pain that the patient is experiencing. Clinically, there is rapid progression to death. Necrotizing skin infections may occur with simple minor skin injuries, muscle sprains or strains, insect bites, or may occur postoperatively, especially in OB/GYN procedures. They may occur in immunocompromised hosts, although many are perfectly normal adults or children. There are multiple etiological bacteria that are found, which we will discuss, that are called type 1, type 2, or type 3. However, the approach to the diagnosis and treatment of necrotizing skin infections is the same. Necrotizing skin infections have been described in the history for many years, including the time of the Civil War. And recently, over the last 20 to 30 years, there has been an increase in the incidence of necrotizing soft tissue infections. In the past, the British tabloids have coined the term flesh-eating bacteria. However, this is a misnomer, as there are many different types of bacteria that can lead to these necrotizing infections. There's often a misconception that these patients have to have significant risk factors to develop necrotizing skin infections. These generally do include diabetes, alcohol, elderly patients, surgical procedures or cuts or sprains, obesity, immunosuppression. However, I would like to emphasize that many patients with necrotizing skin infections are perfectly healthy and young adults. An excellent review of necrotizing skin infections can be found in the New England Journal of Medicine in December 2017 by Dennis Stevens. The textbooks generally describe three types of necrotizing fasciitis. Type 1 is considered to be polymicrobial and may have gram-positive and gram-negative organisms found on the culture or gram stain. These generally occur in elderly patients or diabetics or patients with pressure ulcers. Type 2 necrotizing fasciitis is generally considered to be group A strep or strep pyogenes and staph aureus and vibrio. Type 3 necrotizing skin infection is due to Clostridia infections that results in gas gangrene. This indeed is very rare, although this is generally what most clinicians think of first. Type 1, by some studies, has been found to be most common. Type 2 involves group A strep or strep pyogenes and staph. However, all need urgent surgical evaluation, as any delay beyond 6 hours will increase the patient's mortality. Let us consider the factors first that confer a predisposition to necrotizing soft tissue infections. As I mentioned, generally one looks for a skin breach, which could be a paper cut or a knife cut, but it may be varicella lesions or acne, insect bites, or injection of drugs. Usually a skin break will result in type 2 necrotizing fasciitis, which is generally streptococcal myonecrosis from strep pyogenes or group A strep. Sometimes injection of drugs with the dirty needles may lead to gas gangrene, which is generally Clostridia infections. Another area is minor non-penetrating trauma, which is rather surprising as these are often muscle strains or sprains or contusion, which also generally leads to streptococcal strep pyogenes infections. A rather rare but interesting skin infection that is necrotizing occurs in patients with end-stage liver disease or cirrhosis with ingestion of raw oysters that generally come from the Gulf, where there is 100% infection with Vibrio vulnificus present in these oysters. Therefore, patients with cirrhosis should be specifically advised to avoid ingestion of raw oysters, as this is a very significant infection with a gram-negative organism. The clinical symptoms generally are similar regardless of the cause of the necrotizing skin infection. Initially, the patients will experience a viral type of symptoms, including myalgias or perhaps abdominal pain or muscle cramps or weakness. The pain, which is often in the extremities, is severe and deep in the muscle and joint, or feels like the pain is in the bone. Often there is confusion, delirium, or mental status change present, so always look for that or ask family regarding confusion. Patients on presentation often have a very high fever associated with rigors. In physical examination, one will notice a skin rash with a violet, bluish discoloration or blistering. This generally is an extremely important sign that the patient has necrotizing skin infection, and these will spread rapidly along the extremity or abdomen or the site of infection. The patient rapidly progresses to septic shock. The site of entry may often not be immediately visible. The sites of necrotizing skin infection generally is the extremities. 75% or more extremities leads to this infection. However, other sources of infection may be the neck, the lung, peritoneum, or genitalia, which leads to what is called Fournier's gangrene, abdominal wall, as well as colon and peritoneum. There's often confusion between necrotizing skin infection and the bread and butter cellulitis that we often see very frequently. Cellulitis is generally slow and indolent. The pain is not severe. There are no systemic signs of sepsis or septic shock or multiple organ failure. Lactic acid generally is normal, less than 2 millimoles. There is no significant bandemia. This is generally a slow process, and the symptoms have been present for several days prior to arrival to the emergency room, and these patients respond to broad-spectrum antibiotics and have a low mortality. In contrast, the necrotizing skin infections that we are challenged with present with sepsis with organ hypoperfusion or severe sepsis or septic shock. The patient may be hypotensive, hypoxemic, have increased lactic acid greater than 2 millimoles. They may have an elevated creatinine with evidence of acute kidney injury and DIC, thrombocytopenia, or they may have liver dysfunction. Any one of these organ failures signifies that the patient has severe sepsis. The patient may already be in septic shock by the time that they arrive to the emergency room. Let us discuss in detail group A streptococcus or strep pyogenes, as in my experience, this is the most frequent type of necrotizing skin infection that I have experienced in the ICU. It affects patients of all ages. The portal of entry, as I have discussed, may not be initially found. Bacteremia is found commonly. There's a 30 to 70% mortality depending on early diagnosis and recognition and intervention, and 25% or more patients may require amputation. Group A streptococcal sepsis is estimated to occur in 5 to 10 cases per 100,000 population. The virulence has changed as populations have lost herd immunity. Group A streptococcal sepsis is due to 18 myotoxins that leads to muscle damage, M1 and M3 being the most dominant. Group A strep also creates 5 streptococcal pyrogenic exotoxins, which is called a superantigen that leads to high fever. The evolution of necrotizing fasciitis or myonecrosis is interesting. Approximately 50% of the patient will have a defined portal of entry, where there is a skin or mucosal breach that leads to the organisms and exotoxins invading the deeper layers of tissue. As we see here, as the exotoxins spread, there's platelet leukocyte aggregation and damage to the blood supply. This area then becomes further ischemic, and you get bully and ecchymotic discoloration of the skin at the surface. As this infection progresses, it leads to vascular occlusion, necrosis in multiple layers of the tissue, and damage to the muscle that becomes ischemic, and this infection then spreads very rapidly. On the outside, I will emphasize again, you see these violent bully and discoloration, and these often can be stained with the gram stain and show gram-positive cocci in pairs and chains. More challenging for clinicians is when there is no defined portal of entry. This tends to occur when there's a deep tissue injury from a muscle sprain or a strain, and if, unfortunately, at that time, the patient develops bacteremia with group A streptococcus, you get further inflammatory response deep in the tissues, the release of exotoxins, venous occlusions, platelet aggregation, and further arterial occlusion and ischemia, which then travels upwards, and you get the manifestation clinically of erythema, ecchymosis, and bully formation much later in these patients. The evolution of physical signs in necrotizing fasciitis is therefore interesting, and the clinical staging of the disease has been proposed. These symptoms may occur over hours. Stage 1 is when you notice the erythema and there is warmth to palpation on this area of infection, as well as tenderness to the palpation and swelling. This may progress rapidly within hours to blister or bully formation with violet discoloration, and the serous fluid of the dishwater pus can be seen at this time. There's skin fluctuance and there's skin induration. And the late stages show hemorrhagic bully, skin anesthesia, crepitus, and skin necrosis with dusky discoloration and frank gangrene, as I will show you in these cases. This is an initial case where the patient was seen in the urgent care clinic. She's 61 years old, and she wakes up with swelling of the olecranon versa associated with fever and severe pain. In the urgent care clinic, her temperature is 103. However, she is hypotensive in the urgent care clinic, and she is given IV fluids and antibiotics and transferred immediately to the intensive care unit. 12 hours later, the patient is in profound shock, ARDS, and has extensive damage to her extremity, which has spread further up her arm and down her arm, which requires an amputation or disarticulation at the shoulder. Further cases similar show the prominent skin discoloration that I have mentioned, which is the violet discoloration, which is the tip-off sign that the patient has a necrotizing skin infection. This is associated with severe pain and tenderness and rapid spread. Here is another example where one sees the violet discoloration and the blue blisters as mentioned in the article in the New England Journal of Medicine. The breach in the skin may not be visible, as in this situation, and the patient may have developed this from a muscle sprain or strain at the time of being bacteremic. Here's another example of the blistering and discoloration and severe pain and pus that is relieved from these blisters can be gram stained to look for either strep or staph. This patient's appearance is more consistent with the staphylococcal scalded skin syndrome, which is causing the necrotizing skin infection. However, microbiological diagnosis is required. Here is another example of the violet blue discoloration with blistering and erythema, which is now spreading into the thigh area. This requires urgent surgical intervention and fasciotomies and debridement and possible amputation. Here's a case of a very late presentation, which includes areas of dead, denuded skin, as well as the blue blistering and violet discoloration that is typical and classical of necrotizing soft tissue infection. The lab findings may also be very helpful in evaluating these patients. Generally, the white cell count is only mildly elevated. However, there is significant bandemia with more than 20% bands as a striking feature in necrotizing skin infections. There's often multiple organ failure, including acute kidney injury. CPK may be helpful and is elevated if there is muscle injury. Platelets are often low, albumin level is low, and notably the serum sodium is low. There is evidence of multiple organ failure, including renal failure, hepatic failure, hypertension, metabolic acidosis, including severe lactic acidosis. A C-reactive protein, if obtained, is generally over 15 to 20 range, and a procalcitonin level will be markedly elevated, especially if the patient has bacteremia. Gram stain and culture of the fluid obtained in the emergency room from aspiration or at the time of surgery reveals generally group A strep, Staphylococcus aureus, which is type 2 necrotizing fasciitis. Again, I would like to stress that patients with liver failure may have Vibrio prolificus from eating raw oysters, and that history should be obtained from the patient, even if the patient resides in California or states other than Florida. Differential diagnosis, one should consider Clostridia infection where gas is present in the extremities, and one only needs to get a soft tissue X-ray to demonstrate the presence of gas in the tissue, which can often be felt clinically. If the patient has cirrhosis, one should suspect Vibrio. Diabetics or patients with chronic wounds, such as pressure ulcers, often have mixed organisms, including E. coli, anaerobes, or other gram negatives. And patients who have been under chemotherapy or immunocompromised, one should also consider Pseudomonas as causing soft tissue infection. It is important to detect necrotizing fasciitis clinically, rapidly. So I would like to focus again and emphasize that the pain is out of proportion to the amount of erythema or discoloration. One should constantly be searching for bullae formation, which is violet in color, with dishwater drainage. The tenderness beyond the area of erythema is quite significant. The patient rapidly progresses to septic shock and systemic toxicity, and the skin appears dusky. In the lab evaluation, look for hyponatremia. White cell count may be normal with significant anemia. There's often presence of renal failure and coagulopathy, and most important, the lactic acid is markedly elevated. The treatment of these patients is the same regardless. One must manage the sepsis with aggressive fluid resuscitation and initiate vasopressors with norepinephrine and admit the patient to the intensive care unit. I also recommend obtaining an echo, as cardiomyopathy is seen commonly in patients with necrotizing skin infection. The patient should have received immediate antibiotics in the emergency room to include clindamycin as a blocker of toxins, especially in group A strep and staphylococcus infections. One should also add vancomycin or linezolid for coverage of staphylococcus. We may add zosyn for coverage of gram-negative or anaerobes. And if the patient has liver disease, one should consider Vibrio and initiate doxycycline 100 milligrams IV BID and request urgent surgical intervention. I must also mention that a frequent use of nonsteroidal for management of pain should be avoided, as it is considered that the nonsteroidal may aid in the progression of toxin in the patients and spread of toxin. Antibiotics generally, as recommended by the society, recommends penicillin if streptococcal pyogenes is identified. Surgical exploration should be performed every 24 hours or 48 hours until all evidence of infection is cleared. Hyperbaric oxygen is often considered, however, this is of doubtful benefit. One should continue clindamycin to suppress toxin synthesis as well as suppress the binding proteins in the cell wall. So let us review the algorithm in a patient with suspected skin and soft tissue infection that may be necrotizing. Initially, physical examination and lab should be obtained, including a C-reactive protein, CK level, and evaluate the lab score that has been shown to be quite predictable for soft tissue infections with necrosis. If the patient does not have any gas in the tissues obtained on a plain X-ray, the patient most likely has gram-positive cocci, which is generally Streptococcus pyogenes or Staph aureus. If the patient is found to have gram-negative rods, one should get a history for Vibrio or infection from freshwater or saltwater lakes or sea, which may require doxycycline. If the patient does have gas in the tissues, as demonstrated by physical examination and plain X-ray, and one finds gram-positive rods in the cultures, this is Clostridia myonecrosis from Clostridia infection, which requires very urgent surgical intervention as well as clindamycin. If the patient does not have systemic signs, this is most likely cellulitis or a cutaneous abscess, and the patient does not require intensive care unit management or a surgical intervention. However, surgical intervention is required promptly if the patient does have evidence of necrotizing skin infection, and patient will require debridement and fasciotomies, where one will notice the gray dishwater pus that has been typical for these kind of infections. Please ensure the gram stain of the fluid, including cultures, is obtained at the time of aspiration and surgery. Fasciotomy should be performed to healthy muscle and tissue. These patients will require daily exploration and monitoring in the intensive care unit. Many of these patients have to proceed to amputation over the next 24 hours if the infection cannot be controlled with more conservative surgery. And I often recommend following CKs daily, as well as C-reactive protein and procalcitonin, in order to evaluate if the infection is responding to the interventions. Early diagnosis is critical, and early debridement is essential for patients to have a lower mortality. If patients receive surgery in the first 24 hours of presentation, the mortality is less than 10%. However, delaying surgery more than 24 hours is associated with an extremely high mortality, up to 75%. The relative risk of death is increased by 9-fold. So the challenges that we have in the diagnosis of necrotizing skin infection is that the symptoms often mimic other infections. The diagnosis is often considered to be cellulitis or muscle sprain, and therefore there is delay in managing these patients or admitting them to ICU, and there's a delay in surgical consultation and exploration. Failure to recognize the signs in labs leads to delay in managing this patient that leads to the loss of limb and life. Further, reliance on CT scan and MRI is often utilized to confirm diagnosis of necrotizing skin infection, which is generally not a good idea and not recommended. In one study, necrotizing skin infection was misdiagnosed in at least 70% of the cases. So in order to increase our index of suspicion for patients with necrotizing skin infection, I have recommended the 4 Bs. These stand for low blood pressure or shock and lactic acidosis, altered mental status or level of consciousness, which is the brain. The third B is bandemia on the white cell count, and the fourth B is the blue blister or violet discoloration, as we see in this image. This will aid us in evaluating these patients rapidly with a high index of suspicion and rapid surgical intervention and ICU admission, and reduce the mortality, which currently stands at about 30 to 70%. So in summary, I would recommend that we improve our diagnostic capability for evaluating patients with possible necrotizing skin infections by recognizing that the pain is out of proportion, and this is a consistent feature. Necrotizing skin infections lead to rapid progression of infection, leading to septic shock, delirium, multiple organ failure, and high mortality. We therefore need a multidisciplinary team to help evaluate these patients and manage them expeditiously, and one should consult our pharmacist for managing the antibiotic therapy. I would recommend initially clindamycin for all patients suspected to have necrotizing fasciitis, as this can block the synthesis and spread of toxins, especially in strep pyogenes. Thank you for your attention.